the 2024 honors track of the Regenerative Medicine program at Sonoran University. This is the first ever debate, and we are going to be talking about the differences of concentration efficacy for intra-articular and extra-articular prolotherapy. First, we have Kenzie. She'll be debating 10 to 15%. Lanny will be discussing 15 to 20%, and Drew will be discussing 20 to 25%. I am very curious to see what kind of information and research we talk about, and please feel free to include your comments and who you think has the best argument and what you think will be the best concentration of dextrose.
Okay, let's get started. I'm Kenzie. I'm going to be doing the 10 to 15% group. Research has consistently shown that 10 to 15% concentration of dextrose for prolotherapy is the most versatile concentration. It's proven to be effective in proliferation, which the original school of thought was that the threshold for proliferation happened above 10%, but that's been consistently disproven through research. It's also the most tolerated percentage of dextrose, so there's less patient complaints of increased pain afterwards, and at the end of the day, we want our patients to be compliant with treatments. So 10 to 15% is effective, and it's also tolerated by patients.
Ladies and gentlemen of the debate, my name is Lanny. Today I will present to you a case for why 15 to 20% is the optimal choice for intra-articular prolotherapy. It's grounded in rigorous scientific research, clinical outcomes, and an understanding of patient safety and efficacy. And I will demonstrate why this concentration strikes the perfect balance between effectiveness and tolerability, as Kenzie has already mentioned tolerability. Many studies show that 20% dextrose delivers significant improvements in pain reduction, functional recovery, quality of life in patients receiving these injections. I have two studies here referenced showing that 20% dextrose for intra-articular injections triggered the inflammatory cascade in a concentration sufficient enough to stimulate healing through fibroblast proliferation, collagen deposition, and cartilage repair, leading to measurable improvements in patient outcomes without overwhelming the tissues with unnecessary hypertonicity, as we can see in higher doses. Additionally, studies show that lower concentrations, such as 10 to 12, while effective, yield less consistent results, especially in patients with moderate to severe. So that may be effective for a mild case, but once we get up to moderate severe, we may need to be looking at that 15 to 20% dose. Conversely, higher concentrations, such as more than 20%, may lead to increased adverse effects like discomfort, overinflammation, and this can decrease patient compliance. If they get aggravated from their injection, they may not return for another one. Okay, so my argument is that 15 to 20% emerges as the Goldilocks concentration. Not too weak, not too harsh.
Very good so far, guys. So I am arguing in favor of 25% dextrose prolotherapy today in the treatment of musculoskeletal pain. I kind of took a different approach. I talked about some research, but I also talked about kind of the history of prolotherapy for a little bit, and maybe some side tangents on theory. I wanted to draw us back to just the history of prolotherapy in general. Dextrose prolotherapy was first used in the 1930s by Earl Gedney. He was a general surgeon at the Philadelphia College of Osteopathic Medicine. And he injected his thumb, and he did this because they found that the American Society of Herniologists used similar solutions to repair hernias. So these findings were originally published in 1937. And eventually, later on, the term prolotherapy was coined by Dr. Hackett not too long after that. I make that point just to really emphasize that we have decades more history of use in clinical practice with dextrose prolotherapy than perineural or other lower concentration dextrose based treatments. And so I feel like that decades of history really contributes to the reliability of the therapy, and I think it's something we really need to consider. On the counterbalance of that, perineural injection therapy, which is, closer, obviously we're talking about 10%, which is going to be a little bit different than perineural. Perineural is a 5%, but us studying and looking heavily into these mechanisms of action that have to do with the lower percent dextrose we haven't done that nearly as much because perineural injection therapy wasn't really invented until around 2005 to 2010 when Dr. John Liftoff completed that process. But so with the perineural injection therapy, it's 5% concentration, it's a little bit lower. So I mention all this, again, just summarizing that we have much less knowledge when it comes to the neurogenic effect that perineural is having on the body. At least we have less time of looking at those mechanisms of actions, and so I think we really need to rely on that bedrock or foundation that we have within higher concentration hypertonic dextrose prolotherapy. Also another thing, we all went to the IR conference and Dr. Dean Reeves presented there. I don't want to talk too much about all this because Dr. Dean Reeves hasn't published his research yet. And so it's unpublished and we don't want to reproduce any of his slides or anything like that. But I think it's reasonable for me to talk about it in a general format of kind of like formalities of what he found. Because he did a really interesting study where he actually injected dextrose into his own knee, and then he aspirated through a needle to see what concentrations the synovial fluid was at certain points in time. And I feel like it's important to mention what he's doing and look out for his research because I feel like it's hyper relevant to this discussion. And the short end of the story that he found was that concentration of dextrose within the synovial fluid drops off very quickly. So the body adapts very quickly, absorbs that fluid, and he made a really strong argument that dextrose isn't as harmful as we really traditionally thought in the realm of dextrose-based treatments, that usually the body probably handles it very well. He made some other arguments that dextrose is really only transiently hypertonic in that it's kind of like a different way of saying that the cell membrane itself handles dextrose very well, so it's probably not as harmful as we thought, and it transports across that membrane and probably not causing as much harm as we had thought. One of the problems in research that we have is concentrations of dextrose in our evaluation. We have studies comparing Prolo to PRP. We have studies comparing perineural to Prolo, but actually we don't have the second one. That was I misspoke there. But what we do have, which was really hard to find, and this study just dropped in 2024, so I thought it would be really relevant to drop out for everybody. There's a study, and it's titled Comparing the Efficacy of Varied Dextrose Prolotherapy Concentrations in Treating Osteoarthritis of the Knee, a double-blind randomized trial. It's really hard to find that double-blind randomized trial. And so I thought it was super relevant because what they evaluated in this study was a 12.5% dextrose concentration versus a 25%. And I'm going to give you guys papers
Lanny.
too.
Yeah. We've all got copies.
So what we now have in the literature is a study which actually looks at varying concentrations. We're not comparing perineural we're not comparing PRP to Prolo. We're actually comparing differing dextrose concentrations. And so I just wanted to briefly read off that the summaries basically. So the highlights of this study were that there are 60 participants aged 40 to 70 with knee OA, and they're randomized into two groups. Baseline characteristics of them all were the same, and so they did an evaluation at 12 weeks. What they noticed was that there wasn't really a statistically significant decrease in pain and an increase in functionality. The group with the 25% did fare a little bit better, but at the 24-week and the 48-week mark, it was pretty statistically significant that the 25% dextrose concentration group actually fared a lot better than the 12.5% dextrose concentration group. And kind of highlights on their methods, they did injections at 0 weeks, 3 weeks, 6 weeks, and 9 weeks. Like we said, 60 participants. Obviously, it's not a huge sample size, so if we could increase that, it would be really helpful. But yeah, I had a couple thoughts just really quickly on maybe why we are seeing that. And I'd like to draw a lot of our attention back to the healing cascade and how a lot of times that collagen deposition doesn't end up happening until months or even multiple months later on. So I think that's something we really need to consider in this evaluation, is that the reason those higher concentrations are not seeing the effect until later on is because it takes a long time for collagen to be laid down. It takes a long time for it to form. And so while I think we're increasing patient compliance and maybe lessening the blow of kind of like the pain flare after a prolotherapy treatment, I do think we're actually lessening the efficacy long term. But that draws into attention very important points about patient compliance and understanding treatments, because patients, if they don't understand that it takes a long time for that collagen to be laid down, they might associate improvements they have, months down the road to something else. Maybe they did another lower level physiotherapy modality months or even years down the road, but really they were laying foundation with dextrose prolotherapy. I know I've gone way over time and I have many more things that I could say, but I want to cut it off because I am very verbose, so I apologize.
Kenzie has a response.
Yeah. So I agree with most everything you said. I think there was a couple of things. So you started talking about this, the research kind of showing that, okay, so you're going to inject 25% dextrose. Basically, if you were to inject 5 milliliters of 25% dextrose in a knee with 24.2 milliliters of synovial fluid, you're going to end up with 4.4% immediately after dilution, based on that study. So, if you're starting with 25%, you're eventually going to get down to 10% anyways. So I guess the question is there really an added benefit with a higher percent dextrose? Because there's also been research with 10% showing collagen laydown, cartilage reformation. So, not really sure.
Coming on fire and hot.
Just while we're going against you, I'll add on to that. In addition to also seeing benefits in the lower doses, what you don't see in the lower doses is that adverse effects such as tissue irritation, significant pain, and inflammation, and sclerosis in some cases. As we know, like 30% is the thought of standard for sclerosis. 25 is pretty close to that. So we do have some more risk.
Very good points, guys. Thank you.
I have one more thing.
You want to say one more thing? Okay. I don't know if I can handle responding to all of them.
Also, so we're thinking, lower percent dextrose might decrease the efficacy of some of these treatments, but it's been clinically proven over and over that perineural with 5% dextrose can treat almost any type of musculoskeletal pain, even deep, organ-related pain or pains that aren't necessarily neurogenic inflammation in nature. So I think to say that a lower dose is not necessarily as effective might be kind of a stretch.
Laney, your remarks about patient compliance, I would be lying if I didn't think that those are very important. I think a lot of times patients, when you're treating patients, you understand that patient compliance is everything. If a patient has a flare and they never come back for anything, like that's an incredibly important point. And if somebody has a bad experience because of that, you really have to factor it in. That's why I think it's really important that if you do take this approach, I feel like patient education is huge, like making patients understand that, hey, this process takes some time and the route we're taking might be a little more arduous at first. It might be a little more painful, but helping them to understand that might, and I was dependent on the patient too. Some patients, they're a little more sensitive, some people aren't. So maybe tailoring it that way. Kenzie, you made a lot of points at me. I definitely agree. Lower concentration dextrose is amazing. Did a lot of that down at NWB with 10%. So I don't really feel like I can argue with you a lot there. I think long-term, if the patient's compliant, 25% is more effective from an intra-articular and extra-articular standpoint. But does that translate into patients on a real day-to-day basis, like where that's what you should use with every single patient? I don't think necessarily that's true, so I agree.
Okay.
Oh.
Sorry, got one more point.
Yeah.
I gotta come for 12.5%. A study published by Dean Reeves, which you actually both have cited. He also posted a study that evaluated 12.5% dextrose for knee OA and said while there was improvement in pain and function compared to placebo, the response was not as robust as higher concentrations in other trials, and the authors themselves suggested a higher concentration might be more effective.
Okay, so going off of that, I have a lot of great research that I found for 12.5%. There's a specific study by, I guess, Dean Reeves was also one of the authors, but the title was Chondrogenic Effect of Intra-Articular Hypertonic Dextrose Prolotherapy in Severe Knee OA. This study used grade 4 knee OA, and they used multiple different parameters. They looked at imaging, they looked at histological changes, they looked at pain scales, and overall the 12.5% was very effective long-term. They also had the follow-up for this it was years, so it was a long-term follow-up. So they kind of had, I feel like a lot of studies either look at, histologic changes or pain scales. They don't look at everything at once, even with arthroscopic examinations of the kind of effects with dextrose. So that was kind of rare to see. Still voting for 12.5.
What would you guys say about the fact that, while we're arguing that this lower concentration that you guys speak of, this lower concentration, is going to increase patient compliance, help it be easier for them to handle the treatment? What would you have to say about, then the patient might have to come in for more treatments? And that's a process too. Do you have any response to that?
I think like you talked about earlier with patient education, that's also important. So you can, inform them of their options and, talk about how if we go with this dose that is known to be effective while also not being inflammatory, you may have to come in a couple more times. And I think a lot of patients would choose that option of not being in pain and getting back to their life.
Yeah, I think it's still too soon to kind of have a definitive answer of how frequently you would need these treatments if you're using a lower dose, because historically we have been using, 15 to 25% usually for dextrose, so it's kind of hard to say, like, giving them a time frame of if we're going to be using 10 or 12%, like this is how often you're going to need to come in, because it really hasn't been done as long. So I think going back to how much history Prolo has and how it's been practiced in the past, it might change, and we don't really have a clear timeline of treatment frequency yet with lower dose.
Do we have any more debate amongst ourselves before we turn it over to the audience?
We already got a question.
Oh, we got a question. Let's give them the mic. You can state your name too.
Hi, my name is Lexi. This is for all three of you. You guys have talked a lot about prolotherapy and intra-articular with osteoarthritis, but is intra-articular versus extra-articular dose dependent on what is effective?
I'll let you go first. Lynn.
Okay. I would like to argue that for 15 to 20%, not only is that applicable to intra-articular, so inside the joint, but at around 15%, it's still considered safe for extra-articular structures, making this an even stronger argument for mine, because when you're in practice, it's the same syringe. You can go and switch from intra-articular to extra-articular and have effectiveness there. 25% would be too high. Extra-articular would be very painful. I'm not gonna argue for the lower dose though.
Lexi, I love your question. It's a very good question. Because microenvironment around a joint and the microenvironment around extra-articular structures is completely different. I feel like the 25% really has the strongest argument for intra-articular injections, and so while we're talking about dextrose prolotherapy traditionally is intra-articular plus extra-articular structures, I think the strongest argument for 25% is intra-articular, just because of one of the points you literally just made, Kenzie, which was that right off the bat, that concentration of dextrose is dissipated when you inject it into the synovial fluid because it's being mixed with the fluid that's already in the joint. That starts you off at a baseline, and even if the body starts to absorb more after that, you're lowering it very rapidly. We don't have that as much with extra-articular structures, so that fluid might sit around a little bit longer would be my assumption. So you could argue that maybe structures are a little bit more irritated and you have a potential for tissue damage, and extra-articular injections would be my thought process. This was how I would think about it. But I might still argue for 25% in extra-articular too, but it's a good delineation.
It's also hard to say too because the school of thought was based around the inflammatory model. 25% is going to be inflammatory, 10% is not going to be inflammatory. It had to be above 10%. But now that they're starting to kind of debunk that inflammatory model, it's hard to say, is there even an added benefit over 10%? Like if you get the same outcomes, given the difference in frequency of treatments. So it's hard to say. I think you made a good point with the intra and extra-articular using, because it was originally 15 for extra-articular and 25 for intra-articular. So, any other questions?
Hi, my name is Chris. My question is, really it's a comment, but I'm kind of erring on the side of Drew's argument of 25% being the optimal dosage. And this just has to do with what you guys were talking about in terms of patient compliance and patient comfortability. When I was a kid, my mom always used to say it has to hurt if it's going to heal. And so, which means that whether it's the inflammatory process or it's the inflammation that's built through other modalities like physio modalities, strengthening the muscles, tendons, or ligaments for that matter, there's going to be pain involved. And so I, as a future doctor, can't really err on the side of the pain. Obviously, we want to judge that, use that as a marker, for healing. But if we know that something is more efficacious but is more inflammatory, and in the 25%, as Drew been saying, then how much do we focus on the pain level in that person, that patient, when we know there's going to be inflammatory processes at bay? Ultimately, the argument has to come from knowing that there's more collagen deposition happening later on, and so we have to have almost like faith. It's like working out and knowing that you have to trust the process, and knowing that if you diet and get stronger, that you're going to get the outcomes that you desire if you follow all the other things strategically, all the other points strategically. And then, to kind of compare that to perineural is kind of a moot point, because perineural, although it helps with neurogenic inflammation, it doesn't really help with collagen deposition. And I think that ultimately we are focusing on collagen deposition in terms of wound healing amongst anything else. That's it.
You want me to go first? Sure. Oh, did you guys hear what he said about? I'm just kidding. Chris, a lot of good points. Just about sometimes pain is not a bad thing. It actually signifies that something really good is happening. And if you have an acute ankle sprain and you're in intense pain and there's shearing of those ligaments, the most healing and the most the biggest load of that healing process is happening right when all of those things are happening, kind of in that acute phase. Not that things aren't happening later, but the biggest load is happening there. So I just have to second a lot of what you said. I think it's all really important and you make good points.
Okay, so just, I'm not gonna argue with your mom, Chris.
Thank you.
But what if I told you we could have that same benefit, that pro-inflammatory response, without the adverse effects, without significant pain? Because yeah, we're putting a needle in a joint. There's gonna be pain. So I'd argue that for all three of us.
Yeah.
There's, no pain, no gain. But in 15 to 25%, we can get that pro-inflammatory response we're seeing with, 25% without significant adverse effects.
And going back to the lower dose dextrose, so you're talking about how, sometimes you do need to have pain and you're more focused on wanting to heal structures, but as we know, when you're in a lot of pain and that TRPV1 signal is, stuck on repeat and the cycle isn't breaking, that's also destructive. So all those inflammatory cytokines are also gonna cause damage too. So it's good to calm down the pain and the inflammation, as well as heal, which is kind of what this dose does at both, it does both at the same time. So, and same with perineural, it can help calm down TRPV1 and stop the signaling and neurogenic inflammation.
I've got another question.
Good argument.
Yeah, that was good.
We got Lexi again, okay.
Okay, it's me again. So this question is directed at Kenzie. So in one of your arguments, you said that, especially with intra-articular knee injections, 25% Prolo will get diluted to about 4%, you said? And so that was about, so what's the difference with the 10% injection? But what would the 10 to 15% injection be diluted to?
Can you do the math in your head? How quick can Kenzie do that?
So that was kind of just an example. It all depends on, the volume of fluid inside a joint. So these were very, rough estimates. So it's gonna be even a quicker dilution for someone with knee OA because they're gonna have more synovial fluid from the inflammation. So that's gonna, even be a quicker dilution because there's more fluid in the joint. Based on that study, he was basically saying there was an equalization. They're kind of debunking the osmolarity theory. So the osmolarity in the joint kind of equalized by 2 to 3 minutes. So the whole idea that it's hypertonic and all of this is kind of debunked. So yeah, that was kind of my point, was starting with 25%, it's gonna dilute down to whatever, 10. I think it's mostly based on homeostasis of the microenvironment. So if you're gonna be injecting 10, maybe it's homeostasis and it's gonna not dilute as much depending on the microenvironment, I guess. Does that make sense? Good question.
Do you have any other questions?
Oh, I was saying thumbs up.
Oh,
Good
thumbs
job.
up, no more questions on that part. So, when you're talking about physical,
You got that. And you could contest Kenzie over here about inflammatory model being moved.
we could go on with contestation on a lot of these different issues. That's why I think that this is a lot of fun having this debate, because you could argue a lot of these different points on what's efficacious and what's not efficacious. But let's say pain is an inhibitor for people to returning back to activity. So if you're not being able to return back to activity, can we talk about the physical therapy model and actually regaining muscle strength and ability to return to activities of daily living with something like 25% dextrose if they are more aggravated?
Funny you asked that. If you open up the, because I was actually reading for this a second time. I think they did in this research study, and again, this is out of India, which I thought was awesome to see prolotherapy research being done out of India. I don't know if anyone else is very pumped about that, but that was awesome to me. But yeah, on the second page, I believe, is in the procedure, they actually did a standardized exercise program was prescribed starting from the third day to the post-injection. So obviously they don't give a lot of details on what they were doing there, but that is one example of, a program where they did a 25%, and I'm guessing the patients tolerated it well. I can't say that for sure because there wasn't really elaboration on that in the study, but I think it's important, no matter, maybe the patients need 5 days after the injection, 7 days, to get to that point where they feel like it's leveled out. Obviously at perineural, sometimes people have increased range of motion the day of the injection, so probably not gonna see that with this, so you might have to give a couple more days before you can start the PT up.
And that's another thing where I think, I agree with a lot of the things we're saying. I think it's the best approach is not one or the other. I think it's a combination of multiple different modalities. Like if we're doing prolotherapy, we know it's going to be inflammatory and cause pain. Why not, end the treatment with perineural just to calm down the immediate, take off that immediate pain rise so they can get back to activity sooner.
Good question.
You have another one?
So can you guys talk a little bit more about what your mechanism of action that you're kind of thinking about is kind of going on? Are you guys able to talk about that at all? A little bit?
It's a good question.
It's a big question. Because I think that you were kind of talking about with your mechanism of action that you were kind of talking about that it's not really an inflammatory process, which I think that it would be kind of challenging, especially in a joint. A joint is mostly avascular, and that's part of the reason why I feel like there has to be other mechanisms of action going on, because you're not really getting that blood flow that's creating the levels of inflammation that you would expect from an extra-articular scenario. And there were and this might be an argument in favor for you, but it would be cool to have the kinetic studies at different concentrations as opposed to just higher concentrations, because the Agarkin study had actually talked about like less than a percentage point of actually causing increasing proliferation of agarkins and whatnot for chondrocyte growth.
So, just so you're asking more about like the inflammatory model, how we can kind of
How you're kind of relating that to the other mechanisms of action and the inflammatory model.
I think it's obviously still it's like the golden question is like what is the MOA of dextrose? So I think a lot of research kind of debunked, the original thought with the inflammatory model was based on, awful research with like cell cultures just being exposed to dextrose at, 24-hour period, and they're just dying, which is expectable. And then I also kind of have an idea that I think it's more receptor mediated, like the pain relief, because when you're doing perineural and you get immediate pain relief from that 5%, there's no way that was enough time to like cause an inflammatory, response or anything like that. So it's so immediate that it seems like there's another mechanism besides the inflammatory model. Do you guys have anything?
I don't have the research with me today, but last quarter I did present on, it's a dose-dependent chondrocyte growth. So this was an in vivo study. This is not clinical, but they did find that higher doses were more likely to lead to chondrocyte growth. So yes, I definitely agree with both of you, and I think this also, in mechanism of action, ties back into that we really don't know the best dose to achieve the varied mechanism of actions.
That is the golden question. And what we've probably spent a whole class trying to talk about, and when we were at IR talking about that for days on end. A lot of good presenters. So I'm not sure I really even have an answer to that question right now. What I can say is maybe some of the mechanisms of action that I feel like excite me the most, as far as looking into more and kind of how they're affecting things. You did mention agarkins. I'm obviously very interested in agarkins, because the idea for anybody out there who's watching this that dextrose is actually causing cartilage production and stimulating cartilage production is just such a cool concept. To think that we're actually affecting the cartilage. You can look that study up if you want. The other study that interests me probably the most is some of the research that Dr. Janzi made us aware of with the epineural CSF vessels and how there's actually this CSF network on, and that relates probably more into the perineural side of things, but it could relate into dextrose prolotherapy too, because if this idea of dextrose diffusing out into cells very immediately and quickly, maybe that low level dextrose is having a global effect on a lot of different tissues. And so those epineural CSF vessels really kind of laying in as possibly an explanation for what we traditionally thought of as Hilton's law, which is that the nerves on the superficial aspect of a joint actually innervate the joint itself. And so that kind of explains why we have immediate effects and decreases in range of motion with perineural injection therapy. I think there's a lot of unanswered questions there, but that's another mechanism that interests me a lot. I do think we need to look heavily, like you made points about a lot, Dr. Dunning, is looking at the inflammatory model. We do know that different cytokines and inflammatory cytokines are affected when dextrose is injected into the joint. And so I don't know necessarily that's completely off the table as far as the inflammatory model being not part of the equation. And I think, as with anything else, probably a lot of different mechanisms going on at once.
Any questions?
Ooh.
Hear from Miss Kylie.
All right, hello, my name is Kylie, and my question for you is more of a practical, boots on the ground question, since you are all three about to graduate and be doctors and be out in the world treating patients. Debate aside, and defending your stances aside, what do you feel would be the most ideal concentration for your patients that you're going to see? And do you think patient constitution is going to affect your decision?
Let's hear it from Kylie.
That is a great question, and I'm excited to answer it, like putting debate aside, because especially in regards to patient constitution, and Dr. Dunning can speak to this as well. We had a patient a week or so ago, and we chose to do lower dose. We chose 11% for this patient, and her constitution was very inflammatory, so we went lower on the inflammation. And honestly, personally, I will consider patient, what was the word? Patient constitution with each of my cases. There's sound research for all three of us, supporting all of the doses. And, I think choosing a dose in the middle that is safe and effective is important. But yeah, I will consider the patient's constitution.
Great question. Yeah, all of our debates aside, I think a lot of us, we probably err on about the same opinion on like how we would actually do it in clinical practice. So while we've done a good job arguing with each other, I think we all agree, and I second most of everything you said. A more petite constitution where the patient is just like going to be more sensitive to treatment. I'm definitely going to go a little bit lower. If they had a really inflammatory picture, I'm going to go lower. If they're able to handle the pain, and also I think gauging patient understanding, because some patients that come in, you can tell they don't understand what's happening. If they don't understand, I'd be worried that they are going to think that this treatment was painful in the beginning process. So I might even just, if I can gauge that they don't understand what's happening, I might go a little bit lower. But yeah, the two things, if their constitution is pretty high and if they understand like, hey, like we might get a better effect, a little bit bigger punch, but the treatment, I might go with a higher concentration.
Yeah, I agree with both of you, and I think that's like the great thing about the art of prolotherapy. We can kind of modify our treatments. We can use multiple different concentrations for one patient if we wanted. If you're treating different structures and kind of coming up with a treatment plan that's so customized to the patient and individualized for every case. So it's nice to have like every tool in the toolbox. So I think I wouldn't discount any of the dextrose concentrations for prolotherapy.
Ready for
question?
closing arguments? Okay.
Or do we have more closing arguments?
Oh, I have a closing statement.
Oh.
You guys can go
I don't know who was voting for this.
In conclusion, 15 to 20% dextrose concentration is the optimal choice for intra-articular prolotherapy. It represents the perfect intersection of safety, efficacy, and practicality, delivers consistent pain relief, functional recovery, supports patient compliance, and remains accessible and cost-effective. Lower concentrations fail to harness the full regenerative potential of prolotherapy, while higher concentrations introduce unnecessary risk.
Since you're making me prep on the spot,
Sorry.
I'm gonna use what, we, in the conventional medical world, we consider double-blind randomized controlled trials as the gold standard, so I'm gonna just read the conclusion to this study. The study compared the efficacy of different concentrations of hypertonic dextrose prolotherapy for knee osteoarthritis. It was found that participants receiving 25% hypertonic dextrose experienced significantly lower pain scores at 24 and 48 weeks compared to those receiving 12.5%. Additionally, functional outcomes favored the 25% category, with significant improvement at 48 weeks. No significant adverse effects were reported. These findings suggest that higher dextrose concentrations offer superior long-term pain reduction and functional improvement. But I agree with you too.
Strong argument.
If I have to choose, I guess, I'll say lower percent dextrose is the best because research has consistently shown that it's just as effective. There's no real added benefit past 10% based on multiple different studies. It's the best because of the great clinical outcome as well as histologic outcome, and there's no bad side effects or increase in pain following the procedure. Okay, I think that wraps it up.
So I'd like to make my closing remarks.
Okay.
I just wanted to say thank you guys for sharing the debate stage.
Yeah, thanks, guys.
You guys
Great
put up a
job.
good fight.
Uh-oh.
Well, thank you guys. I'm very proud of each one of my honors track students. It's great to see their evolution in learning about regenerative medicine. And I think that they all make a great argument for their different percentages of prolotherapy. And I think realistically, the argument is still out. And we'd like to hear from you and part of this debate and what you think, and contribute your research and your understanding of prolotherapy. Or even if you are a patient or interested in receiving services, you'd like to have a little bit more understanding of how prolotherapy affects your specific conditions, please ask us some questions we'd love to answer.
Can we get a vote from our audience member?
Oh, I think that that's fair.
Should we all
Do we wanna, now we'll lead with everything. Jackie, would you like to participate?
I don't think we asked Jackie if she had any questions either.
Did you have questions, Jackie?
No, I did not. Great job, guys.
All right, what's your vote? You're being put on the spot here. What's your vote, Jackie? 10 to 15, 15 to 20, 20 to 25.
I'm thinking the 10 to 15.
Okay.
Say it again.
10 to 15.
All right.
I think I can't pick one for both intra-articular and extra-articular. I say for the intra-articular, based on the arguments presented, I'm going to have to go with Drew with the 20 and 25%, but the extra-articular structures, I'm going to go with Lanny with the 15 and 20%.
I agree based off of the discussion and the study.
25%?
25%
Okay.
And
For
I agree.
intra and extra?
for intro.
Okay, no extra articular comments?
What Lexi said.
Of course.
Yeah, and I agree. Oh, and I agree. Also, 20 to 25% intra-articular, extra-articular. I think that there's no need to have that. And so, Lanny, you got me on the. Let's go. That on the 15, 10 to 15, right?
Yeah. Or
Yeah.
15 and 20.
Oh no, then it's McKinsey. The 10 to 15. I choose the 10 to 15.
You gotta vote.
Yeah. So you got me on that one.
Well, no. Jackie also voted for
Oh,
10 to
yeah,
12,
okay.
10 to 15 as
Right
well.
on.
So you got 2 votes too. All right.
But your arguments were good. Don't get me wrong.
All right. Thanks, guys. We look forward to hearing back from you.